We start with something small and they can get some small wins, whether it's nutrition or exercise, mindfulness, whatever. We start lowering that that level, kind of the barometer or temperature of the immune system in general. Then we can get below that morbidity threshold for whatever it is for that patient. Why can't we call that a cure? And then it might come back, but that happened in cancer. We say we cured the cancer and then it comes back so that it recurs. You can look at it the same way with atopic dermatitis.
This is the Transformational Life Consulting Podcast with Deepa Grandin, MD, where Christians like you get the practical support and tools you need to build your spiritual, mental, and physical well-being, and to guide you on your journey to health and wholeness based on evidence-based science and God's Word. I am your host, Dr. Deepa Grandin. The topic for today's podcast is deep dive into atopic dermatitis. Is this an allergy or a skin problem? How is it different for people of color? There are different types of eczema, but atopic dermatitis is the most common form. Atopic dermatitis is considered also the most common skin disease worldwide. It has widely been described as the itch that rashes. According to a 2022 survey by the International Eczema Council, 223 million people suffer from atopic dermatitis. Of these, 5 to 20% are children. Significant variations are seen among ethnicities. Countries in Africa, Oceania, and the Asia-Pacific region have the highest rates of atopic dermatitis. In the US, African-American children have the highest rates. Yet, the published data focusing on people of color is limited. I often get asked the question, what is causing my eczema? Is there a way I can get rid of it forever? While multiple factors lead to the development of atopic dermatitis, in medical language we say multifactorial, genetic variability results in an abnormal skin barrier function. So people with atopic dermatitis tend to lose water faster than those who do not have this condition. So besides genetics, lifestyle, environmental factors have also been identified as significant contributors to eczema. For instance, studies that focus on behavior of your immune cells have shown how skin inflammation manifests based on environmental exposure and psychological stressors. To help us understand this condition a little bit better, I have Dr. Stephen Lewellis. Dr. Lewellis is a board-certified dermatologist who trained at Stanford and New York University. He is passionate about integrating conventional and functional lifestyle medicine principles to improve health and happiness through the lens of skin, hair, and nail disease. He is the founder of Above and Beyond Dermatology. It's a virtual direct care integrative dermatology center that is on a mission to raise the standard of care by offering personalized, integrative, holistic dermatology care that goes beyond creams and 5-minute visits and recognizes the need to know and treat the whole person by trying to identify the root cause of disease. In addition to his practice, he shares his expertise and experience through his podcast, The Direct Care Derm, as well as the weekly Above and Beyond Dermatology email newsletters. In addition to his website, you can find him on LinkedIn, YouTube, Instagram, TikTok, X, and SoMeDocs. Thank you so much, Dr. Lewellis, for taking the time to be on this podcast.
Thank you very much, Dr. Grandin. That was a wonderful introduction. I appreciate the opportunity to share my expertise and my passions with your audience. That was a beautiful intro to the disease in general. So nice job with that. And I'm excited to share some pearls and what I've been working on over here. So thank you for having me on.
Of course. So can you, before we get into the topic, tell us a little bit about yourself? What got you interested in dermatology, and why do you focus specifically from a lifestyle medicine perspective to help your patients manage their dermatological conditions better?
Sure. I found my passion for dermatology in medical school. I went through various different rotations, and once I found dermatology, I kind of found my people. And I feel like a lot of folks feel that way when they're exploring different areas of medicine. And once I found that, I never looked back, and I've been happy with my choice ever since. I haven't regretted it for a second. And the other side of that coin is I found my people also in the patients, not just the other doctors. These people really care about what they're coming to me for, which is nice. It's not like I have to convince someone to care about their high blood pressure that they can't really see, but is going to, alter their life in really big ways down the road if they don't correct it. But people are their lives are truly transformed in negative ways by skin conditions, and I can partner with them in at least making that a lot better, or sometimes even reversing it, which is great. So that's the lifestyle component to that. It's all interwoven. These diseases of the skin, especially chronic skin diseases, they become someone's life. So it almost is a lifestyle. If you have really bad eczema or psoriasis, that can be your life until it's addressed, because it's hard to think about anything else. So you end up taking time off of work. You don't develop relationships. You don't pursue dreams, all kinds of things. Just spend a little bit of time on a Reddit message board about eczema or something, and you'll see how bad it really is. So that's why I like approaching it from that angle.
Yeah, very true. I mean, we don't even recognize how much of an impact it has on people's lives. And, as dermatologists, allergists, if we can help them, even in simple ways of pointing them in the right direction of daily skincare routine or whatever, it makes a huge difference, even from a mental perspective. So what would, in your opinion, be the cause of atopic dermatitis? Because I get asked this by my patients all the time. Doc, what's causing this? Can you shed some light?
From a more philosophical perspective, regardless of what the cause actually is, I think we as physicians need to do a better job thinking about how we talk about and communicate these things. Because I can say it's a condition that has some genetic predisposing factors, as you mentioned, which we know is true. It has to do with moisture escaping your skin more so or faster than someone with quote unquote normal skin. And that creates a defect in the barrier, and things like irritants and various things can get into the skin more easily, and the skin gets itchy and inflamed. The itchier and more inflamed it gets, the more we scratch, and that sort of starts this cascade. And that is a fine explanation, but somebody still might be saying, well, yeah, but what actually is it? What's causing it? How can I get rid of it? And I think we need to focus more on those things. But what you introduced at the beginning, that was a great explanation, and we know some about the pathophysiology in terms of genetics. There's a protein called filaggrin, a gene that is then translated into a protein that is very important for maintaining the skin's moisture barrier, or what's called the natural moisturization factor, or NMF. And people who have a loss of function in one copy of that gene, that's been the most highly correlated to severe cases of atopic dermatitis, but there are a lot of different genetic components. And it certainly has to do also with where you live, climate-wise. Someone might move from the tropics to where I live in Wisconsin, for instance, and a genetic predisposition that wasn't manifesting in a disease all of a sudden is manifested disease because of their environment, or stress, for instance, can bring out the disease. So thinking about the disease in terms of, you have a background risk of this that's higher than anyone else, but it might not be showing up. But there's this thing called the morbidity threshold, basically a line that you need to get over in terms of it actually expressing on your skin that everything adds to it. A little bit of stress raises that score. A little bit of irritants raises that score. A change in the weather raises that score. And all these things add up. And once you get over that threshold, then you're going to start having the rash on your body. And I think once you start to explain it like that to people, they can say, it's almost like gamifying it. They can say, okay, well, okay, that makes sense to me. Let me see the things in my life where I can take that scale down, but where I can decrease my points in that regard to make me less likely to have a flare. And again, that took me a long time to explain, so I need to think more about how I can deliver that to people. But I think doctors in general just need to be more thoughtful about how we communicate these things, so we don't just sound like textbooks, because that doesn't come across. It doesn't make a difference often for people.
Yeah, because it is not that simple, right? There's so many factors that play a role.
Yes.
And then I think some of the points that you were touching about moving from one country to another, epigenetics is a form of the genetic expression. A lot of times I even have families say, oh yeah, but I never had it. Why does my kid have it? And there are some generational differences in the environment that the individual's genes are exposed to. So there's so much that plays a role. But I think also, being sympathetic and helping them understand that, it's not a simple fix, that so many things can play a role is also helpful. So having that empathy, like you were saying, is really important.
That's the key, just hearing them. Hearing their pain, seeing their pain, acknowledging their pain. That's a big pain point for people. When you go on these message boards, they just talk about the doctor after doctor after doctor, topical steroids, move on, moisturizer, move on. And then it's partly a problem of the system, but we're just not reaching these people in effective ways. So the empathy is a huge part.
Yeah. So you did touch upon this a little bit, but can you go a little bit deeper about the triggers that cause flare-ups? Can you cite examples of irritants that can aggravate the skin condition?
When I'm counseling people who are having trouble, whether they know they have the disease, there's a huge, it runs big in their family, and they just know that it's a fact of their life, or all of a sudden their skin has been fine for 35 years and they're the patient who's saying, why now? Why do I all of a sudden have this now? Because that's a very frustrating thing for people. First of all, what you want to do is rule out other diseases. Even though something looks like atopic dermatitis, it may not actually be. If you have that person who's never had anything and not a strong family history, and all of a sudden they're having these rashes, don't just assume that it's atopic dermatitis. Rule out things like allergic contact dermatitis, something that you would be very familiar with. So go down those roads and explore that. But once you're comfortable about the diagnosis, then talking about triggers is a good thing. Because even if someone doesn't have a frank allergy, like an immunologic allergy to something like poison ivy or nickel or something like that could be causing it, there are irritants that trigger it. And very common ones are fragrances. That's a huge one for our folks with atopic dermatitis. Anything from colognes and perfumes, or just fragrances that are in soaps or shampoos, all the way down to fragrances that may be in moisturizer or detergent, fabric softener. All of those parts of our life can have fragrances in them, and the products we want to steer them towards often have no fragrances. Then other things in the environment, things like dust mites, pollens, mold. Food allergy is a huge question. Food allergies do not cause atopic dermatitis, but people with atopic dermatitis tend to have higher risk of having food allergies. So those are some very common allergens and triggers for folks. And then, triggers rather. And beyond irritants, I mentioned stress, sleep deprivation. Those things can certainly trigger it as well. Changes in weather.
Yeah. Yeah. So, as an allergist, that's always been a challenge for me because a good majority of the patients, it's not really allergy as the trigger, while you might see it as a comorbidity. And like you pointed out, the risk is way greater because the atopic march is there. And one of the challenges that I face as an allergist is because when you start avoiding foods, the risk of developing an allergy to that food increases significantly. So, just having to explain to parents that that's probably not the best route. So really making it more of a method, going in a objective way, having steps to make sure we are ruling things out in a practical way and not, just randomly throwing things out there and saying, no, your baby has never eaten peanuts, so you don't have to worry about not exposing them, things like that, So I think the allergy role is a very tricky one, although dust mites, now we know, for the longest time, there was is there any sense in even doing allergen immunotherapy? But now we see that those who do have the dust mite allergies, and then doing the immunotherapy does help some of them. All right. So as far as nocturnal itch, a lot of my patients tend to feel worse at night. And what is so unique about the timing of itch, especially at night?
There are a couple different things that I think about in terms of itching that worsens at night. The two sides of that coin are our brain's just perception of the sensation of itch. Even if the actual signals that are sending those itch signals to our brain don't change or don't get worse at night, our brain's ability to perceive them gets higher because we have fewer stimuli that are competing for that. So you finally just try to rest in bed. Your mind isn't, you're not reading or working or chasing your kids around. You're just not as distracted. So those itch signals can get through and make a louder noise in your brain. So you're going to perceive them more. That's one side of it. But another side of it that compounds that is there is some data that suggests that the itch signals can actually get worse at night. And within atopic dermatitis, at least, that may be because this thing called transepidermal water loss, which is part of how we measure skin barrier function. The skin loses a little bit more moisture at night. So the skin barrier doesn't work quite as well at night. And then it kicks up again in the morning. So you may, if you have some irritants in the environment where you're sleeping, they might be able to get in more easily. And then, or if you're sleeping with, if the pajamas you're wearing, whatever it is, may be irritating your skin, that could actually make you more itchy because you're getting more irritated. So those two things together can really go a long way in making the itching at night really bad. And then that just triggers a huge cycle of sleep deprivation and all of this that is a huge contributor to quality of life.
Yeah, so it's been a whole field of research looking into the nocturnal itch. And some of the research that I've read and heard is also about the microbiome.
Sure.
How there is variability at night, especially with the viral microbiome. And some of, I've always heard even individuals tell me, oh, I had a fever and it was a lot worse when I was sick. And, some of that inflammatory process gets aggravated depending on what's going on with the body. So I think that is definitely true. The data specifically regarding the viral microbiome, I'm not as familiar with, but no, there's no doubt about it in my mind that but microbiome diversity, both within the gut and the skin. And when I generally correlate diversity of the microbiome to health of the microbiome, sort of like biodiversity. It's better to have more types of plants and animals in an ecosystem than fewer generally. And that will allow the kind of what we call postbiotics, the things that the
good organisms we want there make for our bodies to help decrease inflammation and things like that, or decrease our sensation of itching. So there's no doubt a role being played there, both within the gut and the skin that communicates with the brain.
So you had mentioned about the transepidermal water loss. How is that measured?
I've never actually measured it myself, but it's when people are doing studies of this, my understanding of it is it's essentially a probe that's put on the skin that can measure changes in water vapor, and it's essentially you want to see how per unit of skin or area of skin how much water is passing through the stratum corneum, which is the top layer of skin, onto the actual skin, and then it can evaporate, and then that becomes water vapor, and the sensor can measure that. So the higher levels of water vapor would correlate with higher transepidermal water loss. So I think it's a pretty simple process if you have the probes, but it's not something that a typical dermatologist would have in the office and say, let's measure your epidermal water loss.
Got it. So when you're looking at the pediatric population versus the adults, do you see any striking differences?
This is a fun one for me in clinic. The answer is yes, but I like that this is a thing because it helps me level set with people who, especially parents who are coming in with a baby, for instance. Infantile atopic dermatitis presents in a very different way than someone who's 13 or 14 years old or 35 years old. And these are the kids who have rashes all over their face. They're just covered, and your heart breaks for them and the parents. And it does not look like typical eczema that a lot of people think of. So they get scared, and it is scary the way it looks to a trained person who knows how to take care of it and recognize it. It's not scary as in this person needs to be in the hospital, but it's scary to the parents, certainly. And it's all around the cheeks, the forehead, oftentimes the whole body, the trunk area. It can be essentially anywhere. So I often see infants that have quite a lot, but that facial involvement is really prominent. As a child ages and it becomes more of a pediatric or juvenile atopic dermatitis, the hot spots tend to migrate from those areas to the flexural areas. So this area, the antecubital fossa, the wrist right here, same with on the ankle, the top of the ankle. Neck is a common one. Anywhere where there's flexural areas, and behind the knee, the popliteal fossa. Those are the classic areas in more teenagers and adults. And kids can be, if it's a 6-year-old, it can be a little bit in between, but they're making that transition. Eyelids that can be in anybody. So, but it's very rare to see an adult with atopic dermatitis that's presenting like the babies do, with it all over the cheeks, all over the nose. I would broaden my differential diagnosis. But if I see a baby come in and there's a strong family history, and I always bring in the pediatric textbook, because that is what calms the parents down and says, oh, yeah, that's my baby. I went to a picture and they're like, yes, that's exactly what it looks like. And I say, we can also get them better. And that usually takes care of it.
Yeah. So one of the things, being an internist and allergist, we're always told you have a middle-aged adult, never had atopic derm, to think more along the lines of lymphoma, or,
Sure.
Yeah. So sometimes, like you were saying at the very beginning, we have to also make sure we have our differential clear. And primary immune deficiencies in younger children and the way they manifest is also something as physicians to keep in mind. Why would you say that primary care physicians should learn about atopic dermatitis? Is there anything new for people to know?
Sure. That ties into the point you just made, actually, a little bit. I'm glad you brought up things like primary immunodeficiencies. These are things that we are on the front lines of. Dermatologists, certainly, but we can even encourage primary care physicians to be, because some places have very few and far between dermatologists, let alone pediatric dermatologists. So we want to recognize those things as early as possible. So if you have something that looks like eczema, but it's not responding to medications and treatment like eczema, you got to start thinking about things, especially in a kid, things like primary immunodeficiencies. And in terms of what's new in eczema, there is a treasure trove of things that are here and that are coming. We are living in a golden age of atopic dermatitis therapies, similar to what the psoriasis field experienced over the last couple decades with biologic medications. So it started with a medication called dupilumab or Dupixent, which is a biologic medication that's a monoclonal antibody that it interferes with the interleukin 4 and 13 pathways. And now we have similar versions of those, but we're also targeting the JAK-STAT pathway with things like JAK inhibitors like Rinvoq and Cibinqo. Those are brand names, but you can certainly include the generic names in the show notes if you need to. This has just opened up such an area where you can change these people's lives and save lives. I mean, again, going back to these Reddit message boards, there are people who are absolutely desperate. Like, I am suicidal because, literally, these people are saying these things, and you'll have someone who responds to them, a patient, and say, ask your doctor about Rinvoq. It changed my entire life, and I had tried everything else. So not every one of these new medications works for everyone, but we have a few different ones to try, and we're going to have more and more coming out down the road. So get your patient to a dermatologist as soon as you can, if it's a severe case, and tell them that there's hope. Because if you can at least say, hey, go read about Dupixent or go read about JAK inhibitors for atopic dermatitis, and maybe find some hope in other people's stories. And I'm an integrative practitioner, so I like to think about beyond big pharma type stuff. L-histidine, for instance, is a supplement that people are looking at because this gene called filaggrin, or a protein called filaggrin that I've talked about earlier, actually used to be called histidine-rich protein, and the name got changed to filaggrin. But it's about 10% made up of histidine, and it incorporates histidine really quickly as it's getting built. So there have been actually randomized studies that showed histidine supplementation up to about 4 grams or so a day in adults, and in kids, maybe 0.8 or 1 gram or so in one study, was the equivalent to almost a mid-potency topical steroid like triamcinolone. So very safe, relatively, thing to throw in as a supplement that really does work. And then there's this microbiome stuff. So who knows about the skin microbiome or keeping our gut healthy? Those are definitely ways of just keeping inflammation down in general. Using sprays that contain something called hypochlorous acid is a version of the kind of bleach bath that people may have heard of, but some people are more open to using this hypochlorous acid spray because the term bleach bath just needs a rebranding. Essentially, people are scared of these dilute bleach soaks, but they're so effective for decreasing that staph colonization. So as you can already see, I could go on about this forever, but it's a good thing because we really do have a ton of new stuff. And for the primary care docs, they have a ton on their plates. So just to know a few of those things or have a little handout and say there is so much hope while you're waiting for the dermatology referral, maybe read about some of these things, and then they'll be able to get more out of that dermatology appointment when it comes.
Yeah, so those are some great points. And I think some things that you had also mentioned earlier about things that the primary care physician can put in their armamentarium is just the gentle cleansers, sure. moisturize, which we constantly, try to reiterate to our patients. And then when they do need and they're not responding to, because the majority have the mild to moderate versions or manifestations, which we can try to use the lifestyle day-to-day measures. And then, when you're not responding, definitely have to send them to the dermatologist or allergist for the next level of care. But I very often see patients come in where none of these have been addressed, and they're using Bath and Body and Victoria's Secret, and those are things like the primary care can definitely address. And a lot of patients with those simple changes can also see great improvement before jumping on the biologics. And, so I think that would be, like you had mentioned, good points for the primary care physicians as well. So let's just move on to a slightly different topic. Why would you think that clinicians would need to understand differences and manifestations of skin conditions, as we're talking about atopic dermatitis, in people of color?
This is huge. I would say the number one reason for that is that, as far as I know, most people are people of color, as we would define that term. So that is it alone a really good reason to not just know how to recognize this disease in people who have skin tone that looks more like mine. But the problem is, while most people on the planet have skin of color or with skin with more pigment than mine, most board certified dermatologists, at least in the US, do have skin that looks more like mine due to systemic kind of equity issues in our world. So that is a pain point for patients and for the system in general. So being able to taking the time to learn what these diseases look like in all the spectrum of skin pigment is important, because they do look different, and delayed diagnosis is a problem for people, and it hurts. There's morbidity there. If you're a person who isn't able to work because of your disease, and it takes you 6 months longer to get a diagnosis and good treatment because your doctor isn't recognizing the actual disease and the severity of it, because your skin maybe doesn't look as red or erythematous as we're trained to look for. In someone with type 6 or very dark skin, it's not going to look as red as it does in my skin, of course. So these are just critical to be able to recognize it in all skin types, and use your questions to tease these things out as well. It's not a dermatologist's fault if they haven't had exposure necessarily to this, but it's their responsibility to look into it and try to get extra training, but also just ask more questions if you're not sure of the diagnosis, rather than making assumptions. And maybe you can say, with these couple of questions, and I think I'm seeing an atopic dermatitis pattern, this is likely what it is. So I think that can't be emphasized enough. The importance of being able to recognize this in the diversity of conditions. I have an atlas that I use for patients when they come in. I think it's comforting for a person who has darker skin than mine, for instance, to have me show them a picture of someone who looks more like them than looks like me. And that makes sense to me. I would want to see a picture of a person who skin looks like mine. That's easier for me to understand and relate to. So there are great atlases that have a better diversity of pictures. It's really important. That's the short answer. But I think there are ways that dermatologists can take it upon themselves, especially those who have inherent privilege like me, to recognize that you need to do that to be able to serve a much broader range of people.
Yeah, so I can see I've been very fortunate because I've worked in the Middle East, and a lot of my patients have been patients of color. And one of the things I've noticed compared to most of the presentations done previously, which is basically Caucasian population, there's definitely a texture difference that you can see in involved skin versus uninvolved skin, and derobing is so important. Because you will not be able to see those areas where, they've been scratching themselves to death. And you can see these obvious excoriation marks or scratch marks, which patients may not always feel, like comfortable showing. But once you've given them the opportunity to derobe, and you can have a wider area to examine. So I think all of these also can help individuals who are not always exposed to people of color. Because like you rightly pointed out, erythema is not necessarily what you're looking for. But they themselves will tell you, and you can see it, like like the flexural area, like you were saying, like the neck, behind the ears. So there's definitely a lot of telltale signs that tell you that they're miserable, and these are definitely signs of dermatitis because of the amount of damage they're doing with the itching.
I agree. One thing,
So
sorry, before you
go ahead.
add to that conversation that I forgot to say is the significance of these post-inflammatory pigment changes in patients with skin of color, as opposed to the Caucasian patient, for instance. You look for clues of old skin disease, and that there's often these dark spots or light spots, and these, as a person who with skin like mine, we don't think about the dramatic effect that long-lasting hyperpigmentary changes has on someone's life, on their personal life, on their social work, everything. They're just psyche in general, and they take a long time to fade. It's not okay to just say, yeah, that's okay. It'll take months to fade, and that, yes, that's true, but that's not going to. That's not seeing them for what they're struggling with, and that delayed diagnosis that those populations sometimes deal with compounds that problem. So addressing the post-inflammatory changes, taking them as seriously as the active lesions is important. And I think a dermatologist who themselves has light skin and doesn't struggle with those post-inflammatory changes may not empathize with that as much and may not take it as seriously. So that's a good tip to keep in mind to connect with your patients. If a Black patient, for instance, isn't going to resent me for being white, but they will appreciate me if I say, I get it that your skin responds differently when it's inflamed or after it's recovered than mine does, and your hair is different than mine, and all of these things are different in us, not bad or good, just different. And
That's right.
Because I'm white, that doesn't mean I can't understand Black hair, or I can't know that the way I'm counseling about it or the tips that I'm giving is different than if I was speaking to my mother, for instance. So I think we need to be more direct about that, and people appreciate it. They don't want me to change who I am, but I should be able to empathize and understand a broad diversity of people and how their skin presents.
Yeah. So while I think ethnicity is a social construct, there are variations because of the genetic manifestations, So yeah, acknowledging that is always good.
Absolutely. Yeah.
So how do you decide in your practice, like which treatment type that you're going to give to a specific type of patient?
It's all about shared decision making for me. That is such an important thing to establish from the beginning. And part of that starts with understanding the patient's goals, for instance. Just say, what are you looking for to get out of this appointment? Because I might make assumptions about that from my perspective that are very different from what they actually have in mind. So if you establish that at the beginning, it makes it a lot more likely that you'll come to a decision in the end that really supports that person's goals. And then we talk about severity and how much it's affecting their life. I don't rely only on the distribution and amount of the atopic dermatitis or any disease that it is to decide the severity or how far we should go in terms of medication. A person could have it only on their face, for instance. It's really bad around the eyes and maybe the neck and nowhere else, and maybe it's 1% body surface area. But that in a certain patient could be warranting of a biologic like Dupixent or one of the other kind of bigger medications. So it's all about how it affects the quality of that person's life and what risks they're willing to take. And then we talk about risks and benefits. I try to frame them in ways that people can understand, maybe show some actual data, give some real world numbers, show some before and after photos, and understand whether they're open to having an injection or they'd prefer a pill. And all of these things go into it. But it starts with understanding the patient, and then it makes the rest of the conversation so much easier because I'm making fewer assumptions because I'm going on information that they provided me rather than that I assumed.
Yeah, I think it goes back to what you said, seeing, hearing, and letting them know that, they're being heard. That's so important. Because I've had, to me, Dupixent seems like such an easy fix.
Yeah.
But there are several patients that are terrified with self-injecting.
Yeah.
And so, yeah, definitely talking to them, letting them know what other options there are is definitely crucial. So you did talk a lot about, the shared decision making, which is very important. And that's the reason why we discuss treatment options. It's not just the fact that it's so expensive, but what are the potential side effects? So do you have specific tools that you use to inform your patients about the various risks and benefits of the different treatment options?
I like to use visual aids whenever I can. A lot of the companies there's some bias involved in this, of course, and you always have to acknowledge that. But if I'm saying Dupixent again, I have occasional relationships with some of these companies, but I only speak in terms of consulting, speaking, things like that. And I always want to just disclose that. But it's for medications that I believe in and that I use. And if I have something in my office and I'm thinking about using Dupixent anyway, and there's a really nice graphic with before and afters and all of the information in charts with the most common side effects and how frequent they are and all of that, that's so much better for patients understanding of it than me just saying those things out loud. So I really like visual tools. They complement what I am going to be talking about. So that's very helpful. And other tools, sometimes samples, for instance, I guess could be considered a tool. I like the idea of having samples in my office that we could get started right away because access is such an issue. So if you start going through the insurance process for getting one of these medications, it can take a long time, unfortunately. It can be a lot of work for all parties involved. So if I can try some samples first and say, let's see if this actually works. See if it helps you. See if you have a side effect right away. Let's see if it's worthwhile going down that rabbit hole of getting authorization from the insurance company. And then we can save ourselves some time if we rule out right away that this one actually isn't going to work for whatever reason. Let's move on to the next one. So I'd say visual aids and samples are some tools that I use. But again, sorry, the samples aren't so much for the side effects you mentioned, but in some sense it is, because you can say, let's try it for a month. Let's see if you have any of the common side effects. And if you don't, that's a much more likely to be a good medication for you.
Yeah. I always try to have handouts, which is written in a language that patients can understand, because sometimes they Google search and it can be very scary because even aspirin has 2 pages long with side effects, So, and I totally agree. Visual aids are great. And I think a lot of the reps can also provide some posters that, that point out how it's administered, what are the potential side effects. So there's a lot of transparency up front, and patients that's, because it's like building trust and letting them know we got your back and just not, trying to put meds on you for the sake of getting rid of, this, you're here for 5 minutes, like you were saying, now please leave.
Yeah.
So yeah, making sure they're comfortable with the information you've provided. So yeah, the more they are able to relate to the information, and that's like a picture speaks 1,000 words. So definitely visual aids are.
Health literacy is a big deal. We need to, even when you just think about going outside of medicine entirely, just think about how marketing companies think when they're advertising just to people. They're not going to be speaking in this kind of 12th grade or college or way. It's a way that most people can understand, and doctors need to be able to do that too. And we can do that. It just takes a little bit more thought on our part, and that is part of our job. So if we want to do a good job at our job, we need to make sure that what we're saying is being heard and understood by people. And again, you mentioned language. We can translate things whenever we can. Just do our best to meet people where they are, and just to give them as good an experience as possible, regardless of their background.
Yeah. And I think with health literacy, like you brought up, it's not just their level of education sometimes, because even with physicians, sometimes I have to go down to basics.
Yeah.
They're like really very smart people in the marketplace, but you still have to start with basics, and then you can always tell them, hey, if you already know this, I can skip through all of these and we can get to the part that you're not very clear about. So yeah,
don't make assumptions. That's a great point. Like, don't say, oh, this is another doctor from down the street, so I go up to this. That is a really good point, that you should still start at the basics, and maybe move a little faster if they're saying, yeah, I got that.
Yeah, because it's not their field, and not everybody keeps up with everything. So what would you say are some of the unmet needs in the field of atopic dermatitis? Where do you think we need to focus our attention next?
If we hadn't already talked about it, I would certainly talk about doing a better job addressing a more holistic version of human beings in terms of background, skin color, and also just experience of life and how the disease affects them. But we already addressed that. So the unmet need, at least that I'm trying to address, is giving people a better experience from a dermatologist. And this is not the fault of dermatologists. It's to some extent the fault of the system and the fact that there are just not enough of us. But I want to do a better job in terms of resource matching, finding the people who really need a significant amount of time with a dermatologist and matching them with me and people like me who are trying to do these things. And the people who end up with a dermatologist, but really might not really need one. They just got referred, and just doing a better job, again, resource matching. So it's my job to find those patients. That's marketing, essentially, getting my product to people who actually need a significant amount of time with a dermatologist and value that, and then showing them how they can access someone like me. And also understanding that there are people who, even if I'm the guy who's saying we're going to have a 1-hour consultation, we're going to talk about everything in your life, there's some people who just might need a dermatologist, but only need me for 5 minutes. And that's okay too. That's 55 minutes that I get to spend with the person who values and really needs that. So I think that unmet need in a nutshell is kind of addressing what I call the one size fits none problem with more insurance-based medicine. Everybody gets a 10-minute consultation or whatever it is, and then you figure out what they have, and you either are able to solve it, or you're getting behind, or you're not giving them enough time for their appointment. So we need to do a much better job resource matching in that regard. It takes creativity, it takes thought, and a lot of times within a big system, those systems run on volume. They don't run on creativity and innovation.
Yeah. And I also think, there's a lot more research going into personalized medicine these days. And when we're dealing with chronic conditions, because also in my area of expertise, it's a lot of chronic diseases which have very similar underlying factors, like, like asthma, eosinophilic esophagitis, which is the allergy in the esophagus. So I'm hoping also there's a way that we can better control, because I don't know if we're anywhere close to having a cure, but, having better long-term control, or even identifying like the microbiome. To me, I'm very, very interested in the microbiome. I'm hoping we can find some secret there to tackle things early on, so that atopic march is not seen as individuals grow older and get more complicated associated diseases. So yeah, I think we're living in a very exciting time where we can actually offer more hope for people for like the longest time had to just deal with it, and it felt very miserable. But yeah, but I like your thoughts about, the system itself, how much doesn't really help, but sometimes contributes, because we just don't have enough time with our patients to help address all of their concerns. So that's definitely something we can try to change in our own way. Is there anything else, Dr. Lewellis, that you'd like to share with the audience before we end the podcast?
Sure. I think I liked what you just said about we're far away from a cure, perhaps, but that made me think about the way that I used to answer the question of, hey, doc, how long do I have to take this medicine? If they say we got the conversation, yeah, I'm going to try Dupixent, or they come back in 6 months, I'm doing great, 100% better on Dupixent, how long do I have to be on this? When I was in my former practice where I didn't have enough time with people, to be honest, I looked at that sort of scenario as, unfortunately, chronic disease, chronic medication. And that now I look at it as, I'm not sure how long you need to be on this medication. How hard are you willing to work to not be on this medicine? And if the answer to that is hard, or we start with something small and they can get some small wins, whether it's nutrition or exercise, mindfulness, whatever, we start lowering that that level, kind of the barometer or temperature of the immune system in general. Then we can get below that morbidity threshold for whatever it is for that patient. Why can't we call that a cure? And then it might come back, but that happens in cancer. We say we cured the cancer and then it comes back so that it recurs. You can look at it the same way with atopic dermatitis. You can cure it for 5 years and then you can have a recurrence. But that doesn't, the language of cure may still is controversial, but for patients, it could be really motivating. You could say, if you do all these lifestyle changes really well, it's not only is it going to decrease your risk of heart disease and dementia and stroke and all of these things, but you could be cured of your atopic dermatitis for the next several years and just have a recurrence down the road. And then we deal with it because maybe you got divorced and your stress level went up and then you got back over that line. So it's a different way of thinking about it, but I think it's unfair that the oncologists get to talk about cure, but for some reason we have to just say, it's a chronic disease and we're going to try to manage it, right? So, I mean, the cancer is also being managed. It's probably there to some degree when you are in remission, but we call it a cure and we just wait for it to recur.
Yeah. I think from the allergist perspective, we've actually coined a new terminology in asthma. We call it asthma remission. We still don't call it a cure.
Yeah, I think cure is dangerous. I agree with that. Yeah. Remission, that's great because we do that in cancer, right?
Right. And I think we learned that from the rheumatologist because for the longest time with, say, rheumatoid arthritis, being a chronic disease, nobody could see the end of the line for it. And with the newer biologics, they're able to put them in remission. So yeah, I see your point totally. With these chronic conditions, while we may not be completely able to come to a place where patients are never, ever, ever going to need their meds, they can definitely take breaks from it depending on how well we can get them controlled. Yeah. So I would say, being very well controlled, you can reach a phase of remission where you can take a break from having to do so many things, on an ongoing basis. But the lifestyle, that's really important because there's no break from lifestyle.
For sure, yeah, and that's the word.
It's a habit-forming thing that you have to do.
And some people just want a pill. Most people want it
exactly. It's much easier to just take a pill.
If that's the mindset, then yes, it's a chronic disease, chronic medication. That's kind of where I end with those people. Right. But if someone has a different mindset, then let's go for it.
Absolutely.
And language matters. I think if you have a disease and you think about, I can put this thing in remission, rather than I have a chronic disease, I'm trying to manage it, that is going to change the course of your disease. That is not new. It's just psychology and what we know about the brain and all those things that can make a difference, the way you speak and think about the challenges in your life.
Right. Good point. All right. Thank you so much, Dr. Lewellis, for your time. And then we hope to have you in future episodes.
I would love to. Thank you very much for having me. This is a wonderful show. I love what you're doing, and I appreciate your time and sharing your audience with me.
Yeah, for sure. Take care.
Take care.